Well, good morning, everybody. Thank you again for the opportunity to be part of this three-day discussion focusing on the social mission of medical education to achieve health equity. I thought it was a very good day yesterday, and I think very much the reports from the group work yesterday afternoon set the scene for further solid discussion and progress today. And my contribution to that discussion is to focus attention specifically on the community and community engagement in health professional education. I'm going to briefly introduce you to Northern Ontario and then talk about the programs of the Northern Ontario School of Medicine, specifically the place of community engagement. And then I'll share with you some of the early outcomes from our school. So this is Canada. It's north of the United States, and Northern Ontario is this area here, which is north of the Great Lakes. The Great Lakes are just there, and that's Hudson Bay and James Bay. And looking more closely, Northern Ontario in this map is the yellow area. It's very large. It's the size of Germany and France put together, so a geographically vast territory, over 800,000 square kilometres with less than 800,000 people. We have two larger population centres, Thunder Bay here with 120,000 population, and Sudbury here with 150,000 population. There are three other communities with a population of 50,000 or more, and all of the other communities are 10,000 or less. So small communities, large distances. We have a resource-based economy, particularly mining, forestry, and tourism, and so all the ups and downs of the economic cycle. And as a general statement, the health status of the people of Northern Ontario is worse than the general population of Ontario or of Canada. In 2000-2001, there was a widespread community movement across Northern Ontario which said if we're ever going to turn around the chronic shortage of doctors and other health professionals in Northern Ontario, if we're ever going to improve the health of the people of Northern Ontario, we need our own Northern Ontario School of Medicine. The school serves as the Faculty of Medicine of two universities, Lakehead University in Thunder Bay and Laurentian University in Sudbury, and those two universities, those communities are over 1,000 kilometres apart. The school has a social accountability mandate. That's a commitment to be responsive to the needs of the people and the communities of Northern Ontario, with a focus on improving the health of the people of Northern Ontario. And we view the whole of Northern Ontario, the vast geography of Northern Ontario, as the campus of the Northern Ontario School of Medicine. The three factors most strongly associated with going into rural practice after education and training are first, a rural upbringing. That's having grown up in a rural community setting. The second factor most strongly associated with going into rural practice after education and training is positive clinical and educational experiences in the rural setting as part of undergraduate education. And the third factor associated with going into rural practice is after graduation targeted training that prepares the graduate to practice in the rural setting. So that's residency training. Based on that research evidence, we have developed our education and training activities of the Northern Ontario School of Medicine, and I'm going to say a bit more about our curriculum and so on in a moment. I do want to highlight that already we have programs that are not just medical education. It's too fast still, okay, that's right, no problem. I'm going to speak even more slowly. What I was saying is that we already have programs that are not only producing doctors, but other health professionals. and we have research activities which are guided by our social accountability mandate. That is, addressing research questions, the answer for which makes a difference to the health of the people of Northern Ontario. It was mentioned just before about the selection and admissions process for our school. With the social accountability mandate, we set ourselves the target of reflecting the population of Northern Ontario in our class. So we favour applicants who come from Northern Ontario or from similar sort of backgrounds, and you can see we are quite successful. 92% of our students have grown up in Northern Ontario. The other 8% come from remote and rural parts of the rest of Canada. Distributed, community-engaged learning is our distinctive model of medical education and health research that we developed in Northern Ontario. Distributed means that the teaching and learning activity occurs at multiple locations, sometimes at the same time, synchronously, sometimes asynchronously. In order for this to work, we rely heavily on electronic communications to connect all of our communities, and we have over 90 communities, clinical settings, where our students and our residents may undertake their clinical learning. We have an extensive digital library service, which means that if you have access to the internet, you have access to educational resources and information, pretty much the same as if you are in a big city, like a teaching hospital environment. The third component of distributed community-engaged learning is community engagement. That is the interdependent partnership which we have between the School of Medicine and the communities of Northern Ontario, and I'm going to say more about community engagement. This is another map of Northern Ontario, and this one shows you the 90 or more sites, and the colours reflect different components of our education programs. So you can see that our learners, our medical students and our residents and our other health professional learners spend time in many different communities in Northern Ontario. This is the outline of our undergraduate education program. It's a 4-year program. Our students already have a university degree before they start studying medicine. And I want to highlight these orangey-red components. They're the parts of the program where the students are in community settings. And you can see that it's a major component of our program, learning in community settings. In the first 2 years, the students have a half day each week of community interprofessional learning. The students are in health and welfare services, about 1/3, where the doctors are main service providers, about 1/3 where other health professionals are main service providers, and 1/3 which are more community or welfare services, not health services. 3 times in the first 2 years of the program, our students leave Thunder Bay and leave Sudbury, and they go to other communities for integrated community experience. In first year, they have 4 weeks living and learning in Indigenous communities. The students go to these communities. It's usually 2 students per community, and they are in the community to learn from the Indigenous people themselves, about the history, the tradition, the culture, as well as the social and the health issues. In second year, there are 2 4-week integrated community experiences where the students go into small, remote, rural communities, and there they are attached to doctors and the health team. This is a clinical experience in the small, remote, rural communities. Third year is the year where the students make the transition from classroom learner to clinician, just like in other 4-year undergraduate medical programs. However, rather than the students studying their clinical medicine in block rotations, in clerkship blocks, they leave Sudbury, they leave Thunder Bay, they move to another community, and they live in that community. We have 15 communities, large rural, small urban communities in Northern Ontario. The students live in the community for the whole academic year, 8 months, and they're based in family practice. And the students see patients. So you could say the curriculum walks through the door. The first patient might be a child, that's pediatrics. The next patient might be pregnant, that's obstetrics. The next patient might have a surgical problem. The learning objectives in our third year are just the same in the third year of other 4-year medical programs, in the 6 core clinical disciplines, in internal medicine, in surgery, in pediatrics, and so on. However, the learning environment is very different. Our students learn their core clinical medicine from the community family practice perspective. This is a longitudinal integrated clerkship, and there are many examples of longitudinal integrated clerkships in other medical schools where a small number of students undertake this model, and most of the students have the traditional blocks. We are the first medical school in the world where all of the students have a longitudinal integrated clerkship, which we call the comprehensive community clerkship. It is only in the 4th year where the students are in the regional hospitals, the tertiary care centres, and have direct teaching from the specialists and subspecialists in those hospitals. In our program, there is quite a long list of curriculum innovations, and I'm happy to discuss those with anyone later. I do want to emphasise, though, longitudinal learning. And as you've heard, that's particularly a feature in our third year, although it is there throughout our program. And the value is that the students have a broad range of clinical exposure and over time develop a sense of confidence and competence and knowledge and skills. And if they have their longitudinal learning experience in the community setting, then they're learning to practice in that clinical setting. This is learning in context. So my main focus for this presentation is about community engagement. It's about the interdependent partnership between the school and the community working together, not only so that the students and the students' family members feel at home in the community, but also the community enhances the learning experience for the students and help the students to understand the social determinants of health at the local level. I don't want to dwell on this, but just to emphasize that our focus on community engagement is not just about geographic local communities, but also cultural communities. In this case, the Indigenous communities of Northern Ontario. And every 3 years, we hold a gathering where we report to the Indigenous people of Northern Ontario the progress of the school, and we seek their guidance, recommendations from the Indigenous people about how we should develop their medical school to meet their needs. This Walking the Vision gathering was just 1 month ago. We had over 100 people, Indigenous people from across Northern Ontario, and we met in the Chapleau Cree First Nation, the Indigenous community near Chapleau, for 3 days. So we engage with the Indigenous communities and other populations of special interest in Northern Ontario. So making community engagement real in communities requires active participation of the community, and the way that we ensure this is through having what we call the local NOSM, that's Northern Ontario School of Medicine group, which is like a steering committee for the school in the community. And it's the mechanism by which the community is a part of the school and the school is a part of the community. This was mentioned in discussion yesterday, the importance that the faculty members, the doctors and other health professionals in the communities are actually very much a part of the whole school as community engaged faculty members. As I said, Northern Ontario School of Medicine views the entire geography of Northern Ontario as our campus. So our faculty members, wherever they are in small communities and large communities, are on the campus of the Northern Ontario School of Medicine, and we view them as having equal status and equal importance to the other faculty members wherever they are, so that there's no distinction between a faculty member who might be a physician or even a nurse or other health professional in a small community and a subspecialist in the regional hospital, the tertiary care centre. We also make effort to recognise and celebrate the achievements of our faculty members, and this is one page out of our current newsletter, which just highlights the various awards and recognition that our faculty members have received. So making community engagement happen is not easy. It's very, very challenging. First of all, communities are not used to having equal partnerships with universities or medical schools. Their experience is that universities are ivory towers. And if someone comes to visit from the medical school, it's to tell the community what the medical school wants from the community. So it's very much a passive situation of the community accepting whatever they're told to do by the school. True community engagement in Northern Ontario, the community and the community members are equal partners, and they contribute to the development and the delivery of our programs of the school. And so that requires ongoing, continuing involvement. I've just completed over the last few months visiting all the communities in Northern Ontario again and engaging with the faculty members and with the community members as we start to develop the next strategic plan for Northern Ontario School of Medicine. It is very important that the school is visible in the community. So this is the signing ceremony of the collaboration agreement in Sault Ste. Marie, and this sign here is bigger than the sign that tells you you're at the hospital, so that it's very visible to the people in the community that we have this agreement. And of course, it's also very important that we have formal written down agreements which we then hold ourselves accountable to our partners and vice versa. So just briefly, some experience, some early outcomes from the school. First, sharing with you the student experience. These are some quotations from our medical students. Clinical experiences during third year are more substantial than anything in traditional medical school experiences. Creates generalists and encourages students to maintain a broad focus. Rural medicine. That's where you find the true generalists. I like how much variety there can be in the doctor's role. These are the words of our medical students. We're better off. We will learn more skills in the rural centre. You don't know it until you live it. And I think that's a very key message for today's discussion. In terms of outcomes for the school, we had the official opening in 2005, the first graduation 2009. So we've had 6 groups graduate from our undergraduate program. And first, looking at how they compare with other medical schools in Canada, they compare very well. Most years, all of our students are matched to residency in the national residency match in the first round. That is, the whole class matched in the first round. And that hasn't happened for another medical school in Canada for over 15 years. So we take that to mean that the residency program directors in Canada want to have our students, our graduates, in their residency programs. There's a national exam in Canada, the Medical Council of Canada exam, and our students and our graduates compare very well to the other schools in those exams. The big question in Northern Ontario is what career pathway do our graduates choose? And 62% have chosen family medicine, mostly rural family medicine. Now, 62% is almost double the national average for Canada, okay? So almost twice as many of our graduates are going into family medicine compared to the other medical schools in Canada. 33% of our other graduates have chosen other general specialties like general internal medicine, general surgery, pediatrics, and so on. And only 5% subspecialties, like that's ophthalmology, dermatology, radiation oncology. The 5% is important to us for 2 reasons. The first is we need subspecialists like that in Northern Ontario. They have to go elsewhere for their residency, but we expect them to come back. The other importance of the 5% to us is that it shows that studying medicine in Northern Ontario doesn't prevent our students from being competitive and matching to these kind of subspecialty residency programs. There's only a small number of first-year residency places each year in each of the subspecialties like dermatology, radiation oncology. So the fact that our students match to those subspecialties show that if that's the direction they want to go, they are competitive and they are matched to those programs. We also have residency programs, so family medicine and 8 other general specialties, and we know that 70% of our family medicine residency graduates are still practicing in Northern Ontario. I want to take just a moment to talk about the socioeconomic impact. The model that we have in Northern Ontario is more expensive on the input side. That is, the per student, per year, per resident, per year cost is higher than in the traditional model. Lots of students crowded together in a teaching hospital setting. So it's important to look at the big picture. And we studied this a few years ago and showed that for every $1 of Ontario government money spent, there was new economic activity of $2 or more. So the budget that year was $37 million. The new economic activity was somewhere between $67 and $82 million. Okay, so there's a multiplier effect. We also have economic growth, that's new jobs, and economic development, that's new job categories that we would not have if we did not have a medical school. So very important to look at the big picture and the overall return on investment of what is spent in having a distributed, community-engaged medical school. The social impact was also very important. Improved recruitment and retention in the universities of students and faculty members, in the health services of doctors and other health professionals, and that was all good. What was surprising to us was the community reaction. The study was done in 2009, just after the global financial crisis, and you would expect people to be pessimistic about the future. They were optimistic. They were part of the community movement that advocated for a Northern Ontario School of Medicine, and there was a sense of empowerment. If we can do a successful medical school, we can do anything. So, the benefits of the model in Northern Ontario are not just about more doctors, but the kind of doctors, doctors who are members of the health team, responsive to the social, cultural diversity of Northern Ontario. I wanted to mention just briefly the Training for Health Equity Network. The University of New Mexico and Northern Ontario School of Medicine are members, and we have an evaluation framework which I would encourage the group to look at. It is available in Spanish, not yet in Portuguese. In 2012, we had a major world conference, 5 world conferences in one, and the statement from that conference, the Thunder Bay Communique, has a series of commitments for academic institutions, and you can access the slides and read them, but I want to read the last one, which says, provide transformational educational opportunities that maximize the length and strength of relationships with patients, supervisors, and communities, and create authentic workplace learning and identity formation. So, to be successful, you have to be very clear on the goals and keep focusing on those goals, and don't take no for an answer. Next month, there's a conference in Australia, and I'd encourage you to consider coming to attend that to learn more about community-engaged medical education. So just drawing this together, I have introduced you to Northern Ontario School of Medicine and our programs, some early achievements of the school, and I would say in conclusion that community engagement is a key contributor to success for the social mission of medical education to achieve health equity. Thank you.